Welcome back to Voices in Health and Wellness, where we speak with practitioners who are redefining healthcare from the clinic floor to the community. I'm your host, Dr. Andrew Greenland, and today we're talking about something that affects almost every family at some point: rehabilitation after injury or illness, especially for older adults navigating neurological or physical challenges. My guest today is Susan Pattison, founder of SP Therapy Services, a specialist neurophysiotherapy clinic based in Greater Manchester. With over 2 decades of experience, Susan and her team help adults recover and regain independence after strokes, brain injuries, spinal injuries, and long-term neurological conditions like MS. So with that, I'd like to welcome you to the show, Susan, and thank you so much for joining us today.
Thank you for having me.
So to start us off, could you share a little bit about how SP Therapy Services came to be, and what was the gap that you saw in the rehab landscape?
I have always been a very proud physiotherapist, and very quickly I identified that I wanted to work with patients with neurological conditions. I specialised very quickly and loved working with people on their journey. But even I found their journey and their access to rehabilitation was quite short-lived. And their journey was shorter than their potential. And I always felt that very, very strongly. And I took the opportunity to move into a private sector rehabilitation unit, where I had the opportunity to work longer with patients and see them gain more of their potential. But being an inpatient unit, those patients were then discharged, and they were being discharged almost into an abyss where there was no rehabilitation services to support them at home. A long-suffering husband listening to conversations over the tea. And one day I said to him, somebody's got to do something. And he said, And I said, I think I'm going to do this myself. And he said, I wondered when you'd wake up and realise. And so that was the journey. That was the journey I took. It was understanding that patients had rehabilitation potential, understanding that physiotherapy and the other therapy disciplines had the capacity and the ability to change things, but not having the time or the service to do that. And I suppose I always hoped that maybe it would be a self-fulfilling prophecy and I wouldn't have a job because the services would be there. But 28 years later, I am.
Thank you. Tell us a little bit about what you've created. What does your service look like? Who do you have working for you?
Well, we're community physiotherapists, because fundamentally our homes, our communities where we live, isn't it? It's okay learning to walk across the gym floor. That's a nice, flat, smooth service. But our homes are not like that. Our homes are carpeted. The kids' toys are there. The dog's there. We've got to learn to live in our environment. And when people have survived complex injuries, complex brain injuries, complex strokes, when they're living with MS, when they're living with Parkinson's, their physical abilities change. And I felt it was really important to empower them to be able in their own environments. And that's why we chose to start with home visits. I was based in Bury in Lancashire, and I now have team members who are in Blackburn, Lancashire, Bolton, Stalybridge, Barnsley, Bradford and Holmford. So really across the whole of just the northwest and into Yorkshire is how we've set our services up, along the M62, that's how you like to say.
Thank you. So you talked about some of the kinds of conditions that you work with, but what does a typical care pathway look like for a patient with you?
I say there's 2 kinds of pathways that we are involved with. Unfortunately, I take phone calls from daughters or sons who say things like, my mum, my dad was admitted to hospital and they had a stroke. The hospital team have been amazing. The doctors and nurses pulled them around. They've had rehabilitation on the ward. Unfortunately, they have got as far as they can. They're struggling for beds, and my mum is being discharged home. Can you help? So that's one way in which we see patients. And the other way in which patients are referred into us is we work with case managers who are looking after complex needs. And that might be because there's a compensation claim behind because it's been a catastrophic injury. So there's 2 routes really into our service.
Thank you. We've talked earlier about the patient journey from acute to community care. You've kind of talked about the hospital starting point for all this. Where do you see rehab often falling short for people in your experience and across the whole sector?
I think if your diagnosis means you go into hospital, you have the potential to meet a physiotherapist and an occupational therapist as an inpatient, and then you're discharged. And then there seems to be quite a gap in services between inpatient and accessing outpatient services. And I'm sure my NHS colleagues would share my frustration in the fact that, if a drug was working, then a patient wouldn't be discharged without that drug continuity. But it seems, unfortunately, to be acceptable if physiotherapy or rehabilitation is working, that there is a gap before that starts again. The other thing is that not everybody goes through A&E with a medical diagnosis. You can be perhaps living with MS, or you can be living with Parkinson's. And it almost seems that rather than us having a preventative role and looking after people from the start and empowering them to look after their own health and well-being, that we almost wait for it to be a crisis. Perhaps somebody falls and breaks the legs and goes in via the A&E and then picks up the services that then gets referred. So it seems to me as though there are gaps in terms of when the patient is possibly at their most able to access rehabilitation because they're essentially well. Whereas if there is an inpatient, they're fundamentally not well, are they? Because they're being looked after in hospital. Or if they've fallen, again, they're not well. If we could be in, I think we need to, or it's like prehab, isn't it? It's like in football, isn't it? Your physiotherapist prevents the injuries, not sorts them out after the fact. And we spend a lot of time, certainly with our families, engaging in falls prevention.
I was going to come to that as another thing. So especially your work around balance training and falls prevention, especially with older adults. What are the key challenges in that space?
I think the thing is as a physiotherapist, we're an evidence-informed profession, and we are learning more and more and more about balance. And the key thing about balance is the only way to challenge and improve balance is to use it. But that presents us with a clear dichotomy, doesn't it? If you've got a loved one who is a little bit wobbly on their feet, then the carer in you, and not particularly me as a physiotherapist, the husband, the wife, it's like, don't do that, I'll do that for you. So we need people to use their balance to improve their balance. But the dichotomy of that is that if somebody's got poor balance, they're at risk of falls. So the thing is we need to keep them going, but reduce the risk of falls. And sometimes we can end up with well-intentioned people being disabled by love, that things are brought to them. When you go and visit your elderly relative, I would always encourage you that rather than making a cup of tea for them, take them to the kitchen and chat to them while they make a cup of tea, help them look out of the window. But we do tend to, particularly with our elderly, disable them with love by taking away the opportunities for them to be mobile and ambulant.
So disabling with love is one thing, but I guess there's a whole thing about patient confidence as well. So how do you help someone who's lost their confidence after a fall or is afraid of moving too much?
Slowly, gently, with compassion, and allowing them literally to move into the difficult space 1 centimetre at a time. And allowing them to actually use their balance mechanism. We don't have to be thinking about balance in terms of walking on a tightrope or an elephant standing on a ball. That is the very complexities of balance. But certainly reaching into a cupboard to get a cup out, or reaching to clean your teeth, all of these will charge your background balance mechanism and encourage you to get involved in activities of daily living. So that's why I think when we've got somebody who is frightened of moving and we have to improve their confidence, that working with them in their home, with the obstacles that confront them in their home, is the most important. Because what we find otherwise is that patients bring their entire environment in, so that they actually start to reduce their opportunities to move.
Thank you. And what about referrals in? So do you feel that GPs and acute care services are referring at the right time, or is there still a gap? Is there still a gap in when people access the rehab?
I think there's a gap. I think there's a huge gap, and sadly, listening to my NHS colleagues, listening to the magazines that come through with regards to my professional network, it's getting bigger and bigger. The staffing issue with regards to rehabilitation within our NHS, sadly, is not good. I do welcome the fact that we seem to be thinking now about rehabilitation in terms of neighbourhood networks, and that seems to be part of the 10-year plan, but it's a long way away, and we're not in a good place with regards to rehabilitation at the moment. And from what I understand, and my NHS colleagues can correct me, is that often services are limited at the output in terms of they're actually dictated to in terms of how many sessions they can provide, not necessarily what the need of the individual is.
Thank you. Now, thinking about neurological patients specifically, I don't know how it works in inpatient institutions, but I'm guessing there's a certain amount of structured rehab protocols that people are following. Mm-hmm. How do you balance that with perhaps what you want to do with them when you see them and create something which is more individualised and adaptive?
Mm-hmm. I think when somebody's in an institution, there are a lot of controlled structure, isn't there? Breakfast comes at a certain time, drugs come at a certain time. There is a structure within which then it is easy to put. There's specific holes, isn't it, in which you can put things. But real life's not like that. Real life's not like that at all. And the other thing is that when somebody is in an inpatient institution, for example, when I personally have been as an inpatient, I stay at my bed and I stay still. Yes, whereas when you're in your home, you have so many more opportunities to move and engage. So it's making every movement opportunity therapeutic. So it's using cues. So you have your physiotherapy session, but homework is key. So it's using cues. So for example, a great fan of post-it notes above kettles with reminders to stand on your tiptoes whilst the kettle boils. Great fan of a strip of tape down the middle of a mirror, that if somebody has got difficulties with their balance and their alignment, that it's prompting them whilst they're cleaning their teeth. A great fan of engaging family members, such that when grandchildren come round, there's a bucket of activities within which grandchildren can engage with grandma, such that it's not a structured exercise, but that what we're trying to do is, at the end of the day, we're trying to engage people in their everyday activities. If we talk about neuro rehabilitation, the key to neuro rehabilitation are the principles of neuroplasticity, and that means that rehabilitation has to be salient. So it means it has to be meaningful for the brain to learn. So it's really important that particularly when we're working in the home with people, that exercises are not abstract, but they're actually integrated into their everyday activities.
And on that note about neurorehabilitation, which I'm imagining is probably quite a slow process for a number of conditions, how do you measure progress? Because the improvements can often be quite subtle or non-linear. But how do you track things when you're working with people?
I think the most important thing when you're tracking progress is to work out what the patient wants to do. Because at the end of the day, that's what's going to motivate them. And if you're wanting to motivate them, they've got to engage. I might be able to track progress in terms of an outcome measure. Very lovely. My patient doesn't really care for an outcome measure. They're not bothered how long they can stand up for. What they're worried about, or what they want to be able to do, is to stand up long enough to put their shirt on without losing their balance, or they want to stand up long enough in order to make a cup of tea. It's only physiotherapists that actually get excited about the ability to stand and balance. Patients are driven by wanting to do something. So often it's about setting realistic goals. So if I'm working with somebody and they've perhaps recently been discharged from hospital, and they're living downstairs. It could be that they want to walk sufficiently far to get to the toilet independently rather than use the commode in the lounge area. So that's a really valid goal, isn't it? And if you achieve that, that's progress. Yes, often that then leads to, well, what I'd really like to do is go into the kitchen for my breakfast. So then you work to go into the kitchen to do breakfast, and then you say, well, what do you want to do after that? Well, breakfast, dinner and tea. So it's breakfast, dinner and tea. And so it's a cumulative set of goals that are all based on the fact that it's the functional representation of what improvement means to that patient rather than an objective measure, because I'm not measuring populations, am I? I'm trying to make a difference to that individual in terms of their life and their engagement. And I find as a physiotherapist, when you've got a motivated patient, it's cumulative. It's then, well, it's my grandson's christening. I want to go down the steps so I can get in the car. So it's each meaningful goal that we tick off one after the other. I am realistic. I am a physiotherapist. I don't cure the problem. I don't take it away. I am a movement expert, and I analyse movement and function, and I make that movement easier for the patient.
Got it. So with your pacing, because you're essentially pacing and trying to help patients with their goals, do you often find that patients are under-challenged or over-cautious in their recovery before you get to do your thing with them?
Yes. Yes. People are frightened of making a situation worse. And I think we're all beginning to understand that exercise itself is a great is a great medicine for a lot of things, isn't it? Physical activity lowers blood pressure, improves mood, helps modulate blood sugars, all of these things that are very medically orientated that as a physiotherapist I wouldn't particularly be looking at, let alone what it does in terms of muscle function, balance training, all of those skills that I am interested in. We are now understanding much more that exercise is important for brain health, as is brain health is for exercise, and that the body and brain are much more linked than we ever thought they were. And so, yes, I think the tendency is to not do enough. And again, that comes back from a fear of doing too much and hurting yourself.
When you think of all the patients that you've seen and continue to see, what do you think is the biggest barrier to someone regaining their independence after a fall?
After a fall, I think every environment represents a different challenge. So it's not that you recover from a fall, is it? It's that if you've recovered from a fall, then confidence and we know that the fear of falling is one of the biggest predictors of falls. That's something else that we now know. But that fear is environmental specific, isn't it? So maybe you have learned to become confident to move in your own home downstairs. The stairs represent a separate challenge. The steps outside your back door represent another challenge. Walking down your drive represents another challenge. The uneven pavements in your community represent a different challenge. So I would say that whilst fear is a huge indicator of people's potential to fall again, that fear translates. It's almost the better the person gets, they move around the monopoly board, if you like, but there's the next challenge around the corner. So if we just treat mobility and falls in terms of the context of being able to walk 6 meters or something like that, we are vastly underestimating. What we're trying to do, isn't it, is people need to live in their communities. That's where we all live, isn't it? To go to their shops. You cannot be a prisoner in your own home being fearful of falls. I think that's very wrong.
Thank you. What about the really complex cases? Because I'm sure you have those as well, where you've got patients with multiple conditions or multiple comorbidities. How do you help them or put something together for them?
It comes with the nature of the person, doesn't it? These comorbidities do exist, don't they? Often somebody who has had a stroke has also had high blood pressure for a long time, has also been suffering with diabetes, potentially is overweight, potentially has not had a particularly good lifestyle. And when I'm working complex brain injuries, sadly, if perhaps somebody's gone through a windscreen, they've also broken their leg and fractured their ribs and what have you on the way through. As a physiotherapist, then my job is to look at the movement skills that the person has, to look at the potential that they feel they have, and then to build the gap between the two. I have met as many couch potato 40-year-olds as I have enthusiastic 70-year-olds. So I think you learn not to judge the book by the cover. And you just have to take every individual and the problems that they present and their own. And my patients amaze me every single day. You know, they have so much resilience, they have so much potential. They're brilliant.
So moving on to the business side, because SP Therapy Services is a business, what are you most proud of and what's working really well for you from a business perspective?
I think that I'm still here after 28 years. I don't know if that makes me proud or sad. Perhaps sad that rehabilitation is not recognised as a need and I'm still here in the private sector. Proud that as a business I said that's needed and I'm still here providing that. Proud that I've provided jobs. I have 8 staff currently. I've had a number of physiotherapists that have joined us over the years, a number of newly qualified physiotherapists who've joined us over the years, who've been very proud to set off on their journey. I've always been an incredibly proud physiotherapist. Having a business has allowed me to do it my way, and that's what I'm proudest of.
I think you should be proud, and you're clearly fulfilling a very important need. And like you said, you've got people working for you. You're providing service to a good chunk of the country by the way you described the M62. So I think you're doing great work. So well done. On the other side of the coin, what are the challenges or bottlenecks that are most impactful to the business at the moment in your space?
Me, I'm a physiotherapist at the end of the day, and running a business takes other skills. And, I love reading about balance. I love reading about neuroplasticity. Oh, I can, take a book on holiday. I'm happy. But as a business owner, I have to learn about employment law, GDPR, all the other things that come with being responsible. Recently, SEO optimization was my latest thing that I've been learning about and reading into the middle of the night. So I think it's that the hardest thing is accepting that, and it's saying, accepting that being hopefully a skilled physiotherapist, hopefully an enthusiastic physiotherapist, hopefully a physiotherapist who could see a gap in the market was not enough.
I mean, for you, because you wear lots of hats and you've mentioned some of them already, what is your biggest time drain?
Useless worrying. Yeah, I think it comes with. I was brought as a physiotherapist up to be an evidence-informed practitioner and reflective. And being reflective is good. It's really, really good. But you have to watch yourself that doesn't turn into a gnawing guilt that you've forgotten something. It's a bit like when you walk outside the door, isn't it? And you worry that you've left the oven on, and you've not. And just wanting to do the best by my patients and wanting to do the best by my team. But just accepting that I can't know everything all of the time.
Thank you. If you had a sudden influx of new referrals next week, which sounds like a nice problem to have, it might be, I don't know, what would happen?
It's a difficult problem. It's a difficult problem because you want to provide the best for everybody, don't you? I think managing the ups and downs of business is possibly another big challenge, because if you had a crystal ball and I understand you work in an A&E department half the time. I'm sure if you could regulate the flow through the front door,
If only.
regulate the flow through the front door, then that would help. I understand you have triaging practices in an A&E department. We would have to delay the rate at which we could respond. We pride ourselves in being out as soon as the patient needs us, because often when we actually find, patients find us, they've got themselves in quite a pickle, or families have got themselves in a pickle because they've been waiting a long time. And whilst their need is not desperate, as in when they come through A&E, emotionally, they're in a really, really bad place, and we try to get out as quickly as possible. It would delay that.
Right. And are there patients you'd like to spend more time with, but for the reason you've just said, you don't necessarily have the capacity to do so?
You would always like to do more, I think. You'd always like to do more. You'd always like to know more. You'd always like to do more. I think if you work in healthcare, you're pretty much a born rescuer, a little bit. So I think it's the nature of the beast.
I guess I'm guessing at the tension that can sometimes exist between delivering ideal care, which is, I'm sure, what you want to do, but also what's realistically scalable within the resources that you have.
Well, I think the thing is that ultimately I'm not in charge of the resources. The patient's in charge of the resources. And that's quite isn't it? The patient is in charge of the resources. We don't come free. We're honest and upfront about how much we cost. We're honest and upfront with regards to our patients about what we think we can achieve. And at the end of the day, I have to be respectful of the patient, that the patient's funds are their funds, and it is their decisions to what they do. So it's a very different the resources are held by the patient, aren't they? They're not held by me. So I'm not making a service delivery decision based on populations. I'm not saying there is a population of X number of thousands of patients with Parkinson's that I need to deliver, which is how I understand it in the NHS. I have to work their budgets out. A patient is coming to me and they are in control of their own budget. So I think we're coming at it from the service delivery challenges, I think, are different.
Do you have a take on group programs or digital tools or hybrid care models at all? I don't know how it would work in a community setting, but I just wonder whether it's something you'd ever looked at or had a view on.
Yes. I think we ran for quite some time, and it's now we've handed it over to our local university, a hydrotherapy exercise class for people with neurological conditions. But I think there's a difference, isn't there? When we talk about community, there's community as outpatient and there's community as in home visits. And where we work is community as in home visits. So we go into people's homes. I mean, we need to have group exercise sessions that people can go to, but you have to have a set of skills to get to the group exercise class. So, if you there's a lot of work at the moment about falls prevention classes. Great. But you've got to get to the falls prevention class. And if you're too frightened to get out of your front door, we've got a problem. So we've got to go back again and go back into where people's homes are and work within their homes, such that, yes, group exercise is fantastic, but you've got to get out your front door. You've either got to get to your bus stop or get to the taxi or get out the other side. And all of those things can lead to barriers to people actually being included in group activities. But yes, they absolutely have their place.
You've talked a lot about your team on this call, and I just wondered how you've managed to build a team that shares your values and clinical standards, and how easy is it to find the right people?
Physiotherapists are quite a weird bunch. We can get really excited about things like balance and standing very, very easily. I think there are different types of clinicians, aren't there? There are people who qualify that are born to be teachers. There are people that are qualified that are born to be researchers. And then there are people that are qualified that just are born to be with people. And I think you can tell that very easily. And I think I'm very skilled at getting that out over a cup of tea, to be honest with you.
So if you were starting your business again tomorrow, would you do anything differently with everything that you know and the journey that you've been on so far?
Employ a business manager. I think for somebody to take that side away, because you can hear the bit I love. I love people. I love working with patients. I love crawling around on floors, sorting out balance. That's where I'm happy. I understand as a business owner, I have to do the other stuff, but it doesn't light my fire.
And if you had a magic wand and you could fix one thing in the business tomorrow, what would that be?
Can I say something very selfish?
Yeah, please do. It's a free floor.
I'm 60. I haven't got enough time left to do everything I want to do. So I'm going to be Dorian Gray and stick my picture in there and come back at 20 and do it again with all the life experiences I've learned. If you ask me if I can suggest if I would like one thing to happen with regards to not necessarily my business but rehabilitation, is the one thing that drives me absolutely potty is when I come across a patient that's labelled as having no rehabilitation potential. That drives me potty. We cannot identify what rehabilitation potential is. So how dare we label somebody as having no rehabilitation potential? Rehabilitation potential to me is content, context and time specific. We have to put the person in the right environment in order for them to be able to access rehabilitation. You can't say somebody hasn't got rehabilitation potential if they can't see a physiotherapist. That's a service limitation. So I don't think I answered your question there. I think I got what I wanted to say through the back door.
No, you definitely answered it. You made a very good point. And I love your Dorian Gray analogy. That was excellent. But yeah, the rehabilitation potential issue you mentioned is a very interesting and worthwhile one pointing out. So thank you for that. So what about the next 12 months? What does the next 12 months look like for you? Do you have any particular plans for the business? Where do you want to be in a year's time?
We've very excitingly just taken on a new graduate physiotherapist again. When we feel we have the structure within the business in terms of the right support from the right senior members of staff, we can take on a new graduate. We've very excitingly taken on a new graduate. So I'm really excited to see how she evolves. I think bringing a new graduate in is just such a fantastic opportunity for everybody, isn't it? They arrive with their spaniel-like enthusiasm to learn and turn everything upside down with their questions. And also I think it gives the rest of our clinicians a real opportunity to reflect on what they've learned as they teach. So I always find that when we bring a new starter in, it's a very exciting part of the journey, isn't it? Obviously, in my business hat, I'm going to have to sort out a caseload for her to secure her mortgage, which will entertain me on the other side. But that's the bit I'm looking forward to.
With that, Susan, I'd love to thank you so much for joining me today. It's been a really interesting conversation. Thank you for your insights. Thank you for telling us a bit about your work, what you're seeing in the space, some of the challenges of the work, and how it all works from a business perspective, because I think that's important for people listening as well. So thank you very much.
You're very welcome.